Hello and welcome to another segment of Western Wisconsin Journal. I'm Jamie Johnson, the legal and government correspondent, and I guess today I am also a medical correspondent. But with me is a guest who knows much more about the subject than I do, and that's Dr. Paul McGinnis. Doctor, welcome to the show.
Yeah, hello Jamie, good to see you again.
Yes, I think this is your third time, or fourth possibly.
I think fourth, yeah.
Talking about COVID. So it's been around. We are now taping this segment in just right after the 4th of July, thus my flag tie. And this means that we are, 2 years and 4 months into the COVID pandemic. So at least diagnosed cases in the United States. So what is the status as we sit here today in July of 2022?
Yeah, so unfortunately we're still here having this conversation. I think everyone had hoped by this point it'd be over, it'd be done with. And I think a lot of folks are acting as if it's over and done with, but unfortunately it's not. I think there's lots of things we can get on and continue to do normally within our lives, and that's optimistic, but we still have to be aware that it's out there and it can have an impact on us or our family, our friends, and on our community.
Now let me ask, is the original variant of COVID when it was first, the outbreak first started in March of 2022, is that still around?
That's really ancient history at this point. So the Wuhan variant, the original variant, was supplanted in the fall of 2020 by the Alpha variant, and then that was supplanted by a different variant, which was ultimately supplanted by Delta last summer, and now we're into Omicron.
By last summer, you're talking about summer of 2021.
Correct.
And that was Delta, and then Omicron came out January-ish.
Yep. We started to see reports in October or in November, and it started to rise worldwide in December, and it hit this country big time in January and hit St. Croix County big time. Okay. And I'll have Nate put up, but if you look at the county dashboard, you can see each of those peaks that correspond with the original Wuhan variant, then the Alpha variant, and then later Delta, and now Omicron, and now subvariants of Omicron. So it keeps evolving. This thing mutates really fast and changes. Flu doesn't to this extent, and neither does the cold viruses to this extent. So this one is a different critter.
When you say that a variant is supplanted, I mean, what happens that makes it just go away?
So viruses are always trying to reproduce. That's what their goal in life is to reproduce, to find a host, to grow a lot more viruses. So if they figure out a way to be more efficient at that by infecting more people, they want more hosts, then that virus is going to gradually push out the others, so that the virus that I'm going to give you is going to be the most transmissible one. And the virus then you give to the other people around you is going to be the more transmissible one. And the other versions of that just can't get a foothold. So it's, again, kind of that Darwinian survival of the fittest. And
okay.
Omicron happens to be a lot more fit than Delta or Wuhan or some of the earlier variants.
Okay, so let's get into the subject of vaccines, because that caused some controversy. Vaccines first came out and they were limited, and then pretty soon there was plenty, and then there was excess and they were throwing vaccine away. So we're up to now a second booster that anyone that is 60 and over can have.
50.
Now
they
it's
changed
50.
That last month, yeah.
Okay.
The rules change.
All right, so yes, they have all these ages and where we should be with vaccines. Not to mention now eligibility for just any vaccine has dropped to 6 months of age. So
correct.
Let's take these, parse these out. First of all, the young children. I know it had been talked about for months, and it seemed to keep getting pushed back, the approval for those. So what is it that children as young as 6 months, what kind of vaccine are they getting?
Yeah, so that got approved at the end of June, and lots of kids have already gotten it. There's a lot of excited parents out there. Both Moderna and Pfizer had a dosage approved. The Pfizer dose is 1/10 of the adult dose. The Moderna dose is 1/4 of the adult dose. And the dosing interval is slightly different. With Pfizer, you get a third dose. With Moderna, you only get 2. But most people think you're going to need a booster at some point with that as well.
Now, there's another child vaccine that's must have more potency than the one for 1-year-olds. And I'm speaking of the 12-year-olds, that had been approved. So is it graduated, or is it only basically 2 vaccines, kids and adults?
So again, same vaccines for the mRNA vaccines, Pfizer and Moderna, approved from infancy all the way through adulthood.
Okay.
It's the same vaccine. So the vaccine you get is the same vaccine that my grandson got a week and a half ago.
Just dosage is different.
But the dosage is different. Yep.
Okay. And does that graduate depending on the size of the individual or the age of the individual?
It's in age corridors.
Okay.
So,
very good. So what are the risks of vaccine at this point for kids?
yeah, so the risks for kids and adults and everything else, so the vaccine for adults, as you mentioned, has been out for a year, almost a year and a half now, and we have not really seen anything brand new coming down the pike. Certainly not anything that has been to a huge degree or a significant degree. So the things that we saw as side effects and risks with this vaccine back at the very beginning in some of the earliest research is still what we're seeing today. And that's also been true for young children and now also for our infants and for our toddlers. The irritability, fussiness lasts a few days, very few of any other kind of side effects. The studies looked for myocarditis, which is the one that affects young adolescent males that folks are worried about, but they have not seen that in the trials for the younger age groups, that's 6 months to 5 years age, but the studies weren't big enough to really pick it up well. However, we know that that group of children are much less likely to get myocarditis from other viral infections, and the chance of young boys getting it, adolescent boys getting it, we know that existed in the past because of who they are and the hormones and the stage of development, they were a little more likely. And you always weigh this against what's the risk of myocarditis from COVID. Well, it's 10 times the risk as that compared to from the vaccine. So again, slight risk with the vaccine, much greater risk with getting COVID of this myocarditis. The good news is it tends to be self-limited. Kids get and young people get sick, but they recover rapidly.
And then which is still more likely to have longer term risks, the vaccine or actually getting the latest variant of COVID?
There's no question, it's COVID. Long COVID affects as many as 20% of the folks who get COVID, and that includes kids. And that includes kids who have underlying conditions and kids who don't have underlying conditions. It includes older folks and older children who have underlying conditions and who don't have underlying conditions. It includes those who get seriously ill. It also includes those who have very minimal symptoms or even are asymptomatic. So the long COVID is something that medical research is still trying to figure out and still trying to understand. But it clearly is there, and it affects across the entire population, and it's not necessarily dependent on just how sick you got. And that's the hard part.
Question regarding the percentage of people that have been getting the vaccine, and does that have any relationship to the fact that these variants continue to reproduce?
That's a great epidemiologic question. I have not seen clear research to answer your question specifically. On a theoretical basis, I would say, yeah, that's a risk, because if you have a population that's only 63% vaccinated, as we do here in St. Croix County, compared to, say, other places in the country, whether it be California or New York or other places in the world where vaccine rate across the entire population is in the 90% range, does that make a difference? One would argue worldwide it would, but we're still seeing these variants emerge. So it's not a crystal clear answer. What is clear is that those folks who are vaccinated are less likely to have severe outcomes. So when you think about what vaccines do, vaccines are really designed to prevent hospitalization and death, getting really sick. We hope and pray that they will really decrease transmission. In the earlier against Wuhan and Alpha, it was really pretty good, 80, 90+% effective at preventing transmission. Omicron is better able to transmit back and forth between people by a factor of almost 10 times. And so,
is there a little bit of an inverse relationship between the strength or the severity of the variant and its transmissibility?
Yes and no. If you look at Delta, it's much more transmissible than the original variants and also much more lethal. If you look at Omicron, it's much more transmissible than the Delta, but seems to be somewhat less lethal. Although there is debate in the medical circles, the lethality may have decreased because so many people already had some type of infection or had been vaccinated or both or had been vaccinated and boosted. And so that tends to change it. So there's a lot of debate. The general consensus that Omicron is somewhat less lethal. It's not to say that it's not lethal. It's not to say that it doesn't cause death and injury, but it seems like it's a little bit less, but not as much as it appears because so many people have been vaccinated or have had COVID at this point.
All right. Well, let's talk about something that seems to be even less popular than vaccines, and that is masks.
Yeah.
Because, there was what we saw, it seemed to be in the school district, is that there were people who, there's a segment that was clearly against masks, and there were a segment that would always wear masks, and then there was a larger segment that was kind of in the middle that if they're required, they'll wear them. If they're not required, they won't wear them. And we've kind of seen that bear out since the CDC went to the, a little bit more confusing criteria on when to wear masks. So why don't you try to clarify for us, where do we sit with when should people wear masks or not?
Yeah. I think what had changed with the CDC is they changed from a concept of trying to prevent community spread through masking. And
which was the same theory why we were confined to our homes the first couple weeks.
Right, and
it didn't work. Yeah,
that was proved to be, early on, probably not a bit. Going back and you do the same thing all over again, you might still do the same thing because you just don't know how bad it was going to get. And it was bad in places like New York and Washington, D.C. and the nursing homes, and you didn't know what was going to happen. And that's the problem. You just didn't know. But we know that as soon as we figured that out, lockdowns were not a good idea. Keeping kids out of school, not a good idea. But masking actually is very effective if a population uses it. And that doesn't mean wearing it here or over by your ear or down under your chin.
Effective use.
Effective use. And they continue to be highly effective. Our nursing homes have shown that, hospitals have shown that, clinics have shown that, places where people mask all the time. Very effective. But what the CDC switches from that concept of trying to prevent community spread to allowing to do the vaccines and prior infections to hopefully blunt that, and switching it to more just take a look at your own individual situation, your own personal situation, and then make a decision from there. So masking, good idea if you're traveling because you're exposed to tons of different people. Right. You don't know who's got COVID, and you put a lot of money into that vacation, or you're going to visit people or things like that. So there's a lot of value. You're
going into unfamiliar areas, right?
Or you're also traveling through airports, you're standing in long lines, you're on airplanes, you're sitting in crowded gates, all that kind of stuff.
High contact, yep.
Worth considering. I think that's a reasonable idea. Second thing is high risk area. So if you're in a super crowded area, would you consider masking? Perhaps, especially if the rate of community infection is pretty high. But more importantly, if you have health conditions that make you particularly vulnerable, if you've decided for whatever reason not to vaccinate, or there's a population that can't vaccinate for a variety of reasons, then those masks become really important. And it's the N95 masks, the surgical masks that are now used, the cloth masks, again, kind of like the Wuhan variant, kind of ancient history. Don't recommend those anymore. And so also if you have people in your circle, so if you have elderly parents that you're visiting, if you work in a nursing home, you work in a clinic, you may wish to consider handling things different. For instance, in my own personal case, we were out visiting my grandson for his first birthday. For about 10 days before we went there, we masked up pretty consistently when we were in crowded spaces. If we were outside, we didn't. If it wasn't very many people around, if we knew the population we were with and there was pretty high rates of vaccination, we tended to be a little less likely to mask. But then we also tested. We tested twice right before we left to make sure that we weren't taking something to his birthday party that he didn't want.
Okay. Well, let's talk about testing because, I've got some personal stories about that, what happened within our family. But just overall, what's the latest with regard to antigen tests? So
they're still readily available. You can order them from the U.S. Postal Service or USPS.com and get a boatload of them. And they still work. They don't work, unfortunately, quite as well now as they did, say, in the conversation we had, say, 6 months ago or a year ago. We think that's due to a number of different reasons. For vaccinated people, they don't tend to have as many active virus present. Those viruses tend to have more neutralizing antibodies, so the test doesn't do quite as good a job of picking them up. We think there's a variety of factors that makes them just a little bit less effective. But if you get a positive, it's still positive. If you get a negative and you have symptoms, you should be repeating that test 2 to 3 the next day and possibly even the day after, or going in and getting a PCR test. And the PCR test remains, despite all the noise that's out there, a really good test that we use all the time in lots of different areas of infectious diseases to look for organisms other than COVID, as well as COVID too.
Is the PCR test the one that you should be using, for example, traveling?
I would use an antigen test.
Okay.
Okay, so it's still the best option we have. It's still the cheapest, the fastest, the easiest. You can do it at home, 15 minutes you get the results, as opposed to going into the doc's office with the bill and waiting for the results of a day or two. And so from that standpoint, I would use it when traveling. And if you're going to see somebody who's vulnerable, I would repeat it 2 days in a row. And again, it depends on your circumstances. If you just were at the huge parties for the last 3 days with lots and lots of people, I'd be more cautious and test more frequently. If you've only been in your home, only around people who are vaccinated and boosted, I'd probably be a little less cautious, a little less concerned about having to repeat for several days.
When you say around people who have not been vaccinated or boosted, and so, potential exposure, right? Because you don't know who's necessarily having symptoms, who's not. So let's say you find out it's a known exposure, what's the time period that you should be testing after that, regardless of symptoms, and then with symptoms? Okay.
So you're talking about a close contact, that exposure like we've all talked about. So Bob Smith, you were with them for over 15 minutes within 6 feet, calls you up and says, I got COVID, sorry, Jamie. So what I would say then is that the incubation period remains about 2 to 5 days.
Okay.
Before you would start to have a positive test. I would recommend that if you're testing, and I'll answer that question, I'll come back to a different point, but if you're testing, I would start testing, if you have the luxury of testing, around day 3, 4, and 5. That's most likely when you're going to be positive. You may or may not have symptoms, or your symptoms may be incredibly mild. I had a little headache this morning, but my coffee cleared it up just fine, like most mornings. You don't worry about it too much, and you may have just very mild or even truly asymptomatic COVID. Remember, this thing is asymptomatic, and that's been the case since day one with this particular infection. That's been one of the frustrating things. Now, because you were close contact, if you're vaccinated and boosted, so you're up to date on your vaccines, and that means you've had a booster within 4 months, okay? And if you're over the age of 50, then in that case, you can be out and about with a mask on, and you should be wearing a mask full time for 10 days. And that's your protection for those around you, or those you come in contact with, or the elderly person in the grocery store. If you are unvaccinated, or if you've just had an infection and not been vaccinated, then you need to do the usual thing, quarantine for 5 days, mask for an additional 5 days.
Okay.
And again, I would limit contact, so I wouldn't be visiting my 90-year-old mother during that 10-day period of time. I just think that's a recipe for a problem.
Now, then let's take a hypothetical that may or may not have actually happened, and that is a family member starts having symptoms after going to an event with a lot of strange people around. All right, they test positive on day 2 of their symptoms.
Sure.
All right, and then you separate from that family member, sleep in another part of the house, and avoid them and wear mask even within 10 feet of them. Okay,
Yep.
So if you're able to do that and then you remain symptom-free, but you have plans to go and do something, that's why you're staying apart from your family member. Your recommendation sounds like would be to get tested at least once, probably twice before you go to that event.
Right. And I would suggest in that particular scenario, if your event, say, is on Tuesday, I would test Sunday night and I would test Monday night and consider even testing Tuesday right before I went.
Okay.
And that should give you some level of reassurance. And the other thing is, assess the value of the event. Is it really important that you be there? And obviously, for many of these things, it is.
Right.
So,
and but for some people, now talking about my own family, I had like one son get a variant that was back in January. Nobody else in the house got it.
Yep.
Then in May, my wife had it for a week before I did, and then I had it, and I was done with symptoms in 2 days. Same with my daughter, and we were negative tested within 3 days of having first been. My wife tested positive for like 7-8 days. So why the variation within same household?
So I think 2 things. So First off, your son probably had the initial Omicron 1 variant. You probably had, and your wife, and probably had the Omicron 2.21, because that was mostly what was around in May. Now we're moved on to 4 and 5. So I think it's two different variants. I think the second thing, it depends a little bit on when you were vaccinated and boosted. So if you were vaccinated and boosted within 4 months prior to January, you probably still had pretty good protection, and the vaccine did its job. Yep. It kept you from getting it. It protected you. It may have been during that period of time, if you were now beyond that 4-month window, that your antibody levels began to wane a little bit, and that just left you vulnerable to this new kind of a little more transmissible variant, and you picked that up.
Okay.
It snuck in under the door.
And what you're saying makes sense, because based on when I last had my booster and when I eventually got it, it had been more than 4 months. Are you recommending then, because I'm doing the math, 4 months, that means you could be boosted up to 3 times in 1 year, or are they recommending no more than 2 boosts in a year?
I'd say at this point we don't know. Okay. What I can say is that if you are over the age of 50 and your last booster was over 4 months ago, you should be getting boosted now. Okay. If you had an intervening COVID infection, I would still probably recommend being boosted, but you could probably push that out a little bit and just time it out so it works for schedule and life and other things. We know based on some recent FDA actions that they've asked the manufacturers to create a bivalent vaccine, which means it's going to have the original variant and it will have BA4 and 5 in it for use in the fall. And so there will be recommendations for a fall booster. Based on what folks that we've been seeing so far, there's some real concern that we're going to have another outbreak in the fall. As you look at our charts here, November, those are our tough times of year. And it's been true with the exception of Omicron in January.
Right.
There's always variations. But so I think there's going to be a fall booster. So I don't...
Should people wait to get the fall booster?
Again, if you're in those categories where you have an underlying health condition, so if you're 40 years old, diabetic, overweight, and have heart disease, get a booster, okay?
Don't wait.
If you're a pregnant woman, get your vaccine, get a booster, talk with your OB/GYN about that. If you're over age 50, get a booster, really clear there. If you've never been vaccinated, please get vaccinated, because that's going to keep you out of the hospital. It's going to keep you from having really serious illness, and it reduces your risk of long COVID. So the benefits are there and they are great. The risks, minimal. Most everybody I've ever talked to either have minimal symptoms or have one day where they're feeling kind of punk.
And long COVID is still happening?
Absolutely. Mm-hmm. Absolutely. And about 20% of people will get long COVID. I've seen numbers as high as 30%. I've seen it as low as 10%. So seems like the number's sorting out to be about half.
What constitutes long COVID?
There are a couple different definitions out there. One definition is symptoms beyond 2 months. Another definition is symptoms beyond 6 months.
Wow. Okay.
And so World Health Organization versus other organizations. And so if you look at the one I referenced, I'm looking at more the 6 month.
And these most common lingering symptoms, I've heard anecdotally, you tell me if it's medically backed up, but that is the loss of taste or smell?
No, not necessarily. Fatigue, mental fogginess, mental confusion, inability to perform tasks of daily living or normal work functions, breathlessness, shortness of breath, loss of sense and smell. But it's really, the ones I hear about most are more the fatigue, the tiredness. I get up, I do an hour's worth of thing, and I nap for 3 hours.
You mentioned the mental fogginess, and I've heard the term COVID brain, and from my mom who died of cancer, she had chemo brain, she would say. Yeah. So is there a similarity there with the lack of clear thinking?
Yeah, I think similarity from a lack of clear thinking, but not necessarily similarity because of mechanism.
Oh, right.
Because of cause.
Yeah.
But remember, COVID attaches to the ACE inhibitor, that ACE, or the ACE receptor. That ACE receptor is in your heart, it's in your blood vessels, it's in your lungs, it's in your kidneys, it's in your brain. And there's also some distributed throughout the body in the muscles and things like that. That's why this one is different than influenza, and that's why this one, for me, one of the things I worry about, especially for those young children, is we just don't know yet what that infection with COVID is going to do to those receptors and those organs, because we don't have that level of experience yet. So far, it looks like they're going to be okay, but I just worry if you have a 6-month-old or a 1-year-old, what's that going to look like 18 years from now? And I don't know. I'm hoping and praying that it turns out to be okay.
Thank you. I so much appreciate you, bringing your experience and expertise with and knowledge within this area, because we had, the importance of our immune systems has probably been amplified and made known to more people because of COVID. But this goes back hundreds of years. When the first settlers came, we were wiping out whole tribes of Native Americans with things that the settlers were used to, but introducing new organisms
smallpox, measles, mumps.
Right.
Those sound vaguely familiar.
Yes, and that's the thing. Luckily, polio has been limited, smallpox, because of vaccines, but we haven't had the same widespread use of those vaccines like we did with those two. Would you say that's accurate?
Widespread use of which vaccines?
That were the polio and smallpox.
Yes, so polio, widespread use worldwide. Smallpox, much less widespread use now. Our generation, everybody's got the little scars on their shoulder.
Right.
But we stopped using that many years ago. So my kids never got smallpox because it's been eradicated from the world. Monkeypox is a different variant that we could spend another show talking about. So the vaccines were very effective, and they worked, and they really helped to eradicate these diseases. Problem with COVID, it's not that the vaccines don't work. There's two problems. One is the uptake on the vaccines is so much lower in this current environment.
By uptake, meaning?
Meaning how many people get the vaccine compared to how many people got polio or got the mumps, measles, and rubella vaccines, in the past
it's much more
20, 30 years
effort.
ago.
Yes.
Yeah. And much more unified acceptance. I think the second thing is COVID's a nasty bug. It changes, it mutates. So polio's been a stable virus. It's stayed the same. Measles has basically stayed the same. Mumps has stayed the same. It hasn't changed very much. And so that makes it easy to vaccinate for it because you get a lot of protection and it's durable. COVID has changed. We talked about, the original Wuhan. We talked about Alpha. We talked about Delta, which
even
was
more so than the common flu.
Far more.
Okay.
Dramatically more.
Okay. Well, finally, we've talked about the exposure and how long you should wait and so forth. Any new treatments out?
So nothing that we didn't talk about last time in terms of Paxlovid is the go-to drug. There has been some problems with rebound after Paxlovid, but some people will get rebound. There's actually some data suggesting some people with COVID may get rebound even without the Paxlovid, and that you're still by far better off getting the medication and running a slight risk of rebound than letting COVID run rampant.
Okay, but is that the one that you have to get in the first 24 hours of symptoms?
5 days. You got 5 days.
Okay, you do have 5.
5 days from positive test or onset of symptoms. There are also now test-to-treat programs here in our community. Most of the pharmacies have test-to-treat programs. Otherwise, you can go in, they swab you. If you get a positive test, they hand you your Paxlovid.
Okay.
And that's been rolled out, and it's available in New Richmond, it's available in River Falls, it's available here at pharmacies in Hudson. So that's been probably one of the bigger changes.
Higher the age and, I was going to say the shakier the health status, but if you have one of those risks, Paxlovid is something that you should see your physician about?
Right, and I would suggest for anyone who is experiencing COVID infection, it's a good thing just to talk to your physician. I think this is a drug that is not widely available. So early on we were limiting it because there just wasn't as much of it. Now the production's ramped up, it's widely available. Mm-hmm. Why spend 2 weeks or 1 week feeling lousy when you can spend 2 or 3 or 4 days? And that is true whether you're vaccinated or whether you're unvaccinated, both. Whether you recently had a different COVID, so if your son came down again, I would say he should talk to his doc.
Okay. And then finally, what else have we learned that we haven't covered in the previous 30 minutes here? So,
one of the other things that we're seeing a lot of reinfection, and that's one that you hear people talking about. I got vaccinated, I had COVID, and now I got it again. What's going on?
Yeah, I'm hearing more and more people say, I just got COVID for the second time.
Yep. And they got COVID, but they didn't end up in the hospital and they didn't end up seriously ill. So the vaccines and things work. So that's the first point. The second point is that really emphasizes, again, this is a nasty virus that changes and mutates. It's always trying to breed more of itself. It's always trying to outsmart whatever we can do. It's always trying to find new hosts and keep spreading. And so it's mutated. We're now into 4 and 5. 5 is just now 54% of the infections in the state across the nation. Okay. And in the state of Wisconsin, it's taken a big toehold as well. So we know that variant is now the dominant variant. And so I think also people are less cautious. We're going out, we're doing more, we're traveling, we're getting back to normal life, but that also puts us in a lot more contact with folks. It gives that virus a little more opportunity to spread.
So I'm sorry, were you done with
I was going to say one other thing. The original Wuhan variant, if you got it, you spread it to about 1.5 people. The current 4 and 5, you're spreading to 10 to 12 people.
Okay.
So it's that much more contagious.
That much more contagious. So going back to what people can do, I mean, rather than lock themselves in their
don't do that, please.
room all the time, is get vaccinated, get boosted.
Yep.
If you haven't had one in a while, but also the other regular hygiene. Eat your fruits and vegetables, keep your immune system, feed your body well, but wash the hands, especially if you've been shaking a lot of different people's hands. I suppose we've kind of returned to the customs that we had prior to COVID, and I guess it can increase that risk.
Most stores still have hand sanitizer out, and they'd be delighted if you used it up. So those types of things. But I think the other key thing that you left out is stay home if you're sick. If you got a little bit of the sniffles, stay home and test, and then repeat the test. If you get a negative, or go in for a PCR. So you want to find out if you have it, because there's still regular colds around. Those still do happen. But if you're sick, stay home. Even if you have a regular cold, you still don't want to give that to all your coworkers or friends.
Right. Let's say that you do test positive, you have the symptoms, but then you have that day where everyone notices when they can tell when they feel better and they feel like the symptoms are stopping. Sure. How long would you wear a mask after symptoms are alleviated?
So again, it goes back to when you first were positive or when you first developed symptoms, and it's 10 days of mask wearing.
10 days, all right.
That doesn't change.
So whether you have 2 days of active symptoms or 8 days of active symptoms, still use that 10-day rule.
Yeah. The only place I might make an exception is if you are doing, if you're testing and you test negative for a couple days in a row. Mm-hmm. But I still would probably wear the mask. If you're on Paxlovid and you test negative for a couple of days, I would definitely still be wearing your mask because of that risk of a slight rebound. So you may complete your course of Paxlovid and a day or two later start to have some active virus that you could infect somebody with.
Well, Doctor, I really want to say I hope this is the last time we see you on the show talking about COVID, but I have a feeling that we may see you, whether it's 4 months, 6 months, but let's have you on when we can talk about what the difference between pandemic and endemic is, all right?
We're still in a pandemic. It is not yet endemic, unfortunately.
Very good. Well, Doctor, thanks for coming on the show.
Thanks for having me, Jamie.
And I want to thank our viewers for watching another segment of Western Wisconsin Journal. Please be safe out there and be healthy. And thanks for watching.